Okay, thank you, Clive, and I'll go ahead and launch right into it. At the International AIDS Conference in July, some guidelines updates were announced to the WHO guidelines, and I thought it'd be useful to go ahead and review those. I have no relevant financial disclosures and our learning objectives. Hopefully, by the end of this brief talk, you'll be able to describe some of these guideline changes, specifically with respect to first and second line ART for HIV-infected adults, adolescents, and children, as well as some updates regarding post-exposure prophylaxis, and be familiar with some of the evidence supporting these changes. So I'd say the major shift we're seeing from the WHO is a shift to emphasizing dolutegravir-based regimens as first-line antiretroviral therapy. And in this column, TLD stands for tenofovir, lamivudine, and dolutegravir, whereas TLE stands for tenofovir, lamivudine, efavirenz. Note that FTC can be substituted for lamivudine anywhere. But for adult men, adolescent boys, women and adolescent girls with effective contraception or not of childbearing potential, women and young women and who are pregnant at least 8 weeks into their pregnancy, breastfeeding women, adolescent girls, all of these groups, the preferred first line is now dolutegravir plus tenofovir and lamivudine instead of efavirenz. Now, this is the exception, of course, is women who may conceive while on ART or who are in a very early pregnancy. We are avoiding dolutegravir at the moment owing to a signal of possible neural tube defects among infants who are exposed to dolutegravir right around the time of conception. So for that reason, women and adolescent girls of childbearing potential who want to become pregnant, have no effective contraception, dolutegravir is not recommended for those women. Instead, the older sort of tenofovir, lamivudine, efavirenz is recommended. And then, of course, there are alternatives. Some of you may be familiar, there is a lower dose of efavirenz that has been found to be effective as well at 400 milligrams with some reduced sort of neuropsychiatric adverse effects. So that's also an option instead of the 600 milligram dosing in some situations. And then, of course, the boosted protease inhibitors can also be used for first line in special circumstances. This recommendation, the shift to dolutegravir, really comes from clinical trials data that strongly support the efficacy of dolutegravir. This is just a few trials, but there's a consistent theme that we see in these clinical trials. Dolutegravir outperformed ritonavir boosted darunavir. It also outperformed efavirenz and was non-inferior to raltegravir in the treatment of treatment-naive individuals. And then outside of clinical trials, we now have data that were very recently presented from sort of a large cohort in Brazil, where their adult guidelines were recently updated to reflect this switch to dolutegravir. And now dolutegravir-based ART is their preferred first-line regimen. So the Brazilians decided to look and see how well that new regimen was performing compared with prior regimens. And the bottom line is the dolutegravir regimen performs very well on the top line as compared to the previously recommended efavirenz-based first-line regimen. Dolutegravir-based regimens were 42% more likely to achieve an undetectable viral load, meaning viral suppression less than 50. In that Brazilian cohort, about 78% of patients on efavirenz-based first line achieved viral suppression, whereas with dolutegravir, 85% are achieving that, that threshold. So that's some of the data supporting dolutegravir in first-line therapy. There's a similar shift to integrase inhibitors in the guideline updates for children. We do not have dolutegravir dosing guidance as yet for neonates and very young children. In those individuals, generally raltegravir-based regimens are recommended initially, but for children, now a dolutegravir-based regimen is also preferred as first line. We're still working on dolutegravir dosing in pediatrics. We have firm evidence about how to dose it for children who are 30 kilograms or above in weight. But for under 30 kilograms, those studies are ongoing. The WHO estimates that we'll likely have more specific guidance and availability of dolutegravir in children who weigh less than 30 kilograms sometime next year. Okay, for second-line ART, the WHO is now also pushing dolutegravir as the preferred second-line regimen for patients failing a typical efavirenz-based first-line regimen. So this is a shift from the older guidelines that suggested if you fail NNRTI-based first-line ART, you should go to a boosted protease inhibitor regimen. Now it's recommending go to dolutegravir-based regimen. There are data to back this up as well. The most relevant is the Dawning study, which looked at exactly this scenario of individuals failing typical NNRTI-based first-line ART. Individuals were randomized to get the usual sort of second-line regimen of 2 NRTIs plus boosted lopinavir, or 2 NRTIs plus dolutegravir. And the outcomes clearly favored dolutegravir with better success in achieving virologic suppression at 24 weeks into treatment. So to sort of summarize in one chart what is now recommended for second-line ART for adults and adolescents, depending upon what their first-line regimen was. Dolutegravir-based ART is preferred second-line for individuals failing an initial regimen of 2 NRTIs plus efavirenz or nevirapine. If individuals are failing a dolutegravir-based initial regimen, and of course this is likely to come up now that we're shifting to dolutegravir as initial ART, then the second-line regimen is going to be a protease inhibitor boosted regimen of 2 NRTIs plus boosted lopinavir or atazanavir. Similarly, these second-line recommendations extend to the management of children. Dolutegravir is the preferred second-line regimen for children failing a typical first-line regimen that is based on efavirenz or boosted lopinavir. And also similarly, if a child is failing a first-line regimen that is based on dolutegravir, that second-line regimen should be a boosted PI-based regimen. And lastly, the WHO updated its post-exposure prophylaxis guidelines to recommend dolutegravir as the third drug in post-exposure prophylaxis regimens. So in the setting of PEP, for adults, adolescents, and children, you use 2 NRTIs plus dolutegravir. In adults, the 2 NRTIs are tenofovir plus either 3TC or FTC, whereas for children, the preferred NRTI backbone is AZT plus 3TC. So just to summarize the key points, these latest guidelines updates are now recommending dolutegravir-based first-line therapy for most adults and children, the exception being women who are very early in pregnancy or may potentially become pregnant while on ART. Dolutegravir-based ART is now the preferred WHO second-line treatment regimen for most adults and children failing typical efavirenz-based first-line ART or those failing PI-based ART. And dolutegravir is now recommended as the preferred third drug to be added to 2 NRTIs for post-exposure prophylaxis regimens. So I'll go ahead and stop there and open it up to any questions.